Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. I'm your host today, Eric Lim, and we have Professor Samuel Kim from Northwestern Medicine here with us as our special guest this week. This is Premier Education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. The focus of today's topic is going to be strategies to overcome the learning curve in robotic thoracic surgery. Over to you, Professor Kim.
Uh, Good evening here in Chicago, but good morning in UK. My name is Sam Kim. I'm one of the thoracic surgeons at Northwestern Medicine. This morning, we're going to talk about the strategy to overcome learning curve, especially in robotic thoracic surgery. So before I get started, I just want to mention for those people who doesn't know, Northwestern, we're locate hospitals located in downtown Chicago, but we have a lot of satellite hospital around across Illinois. And Chicago is a beautiful place to visit. We're really right next to a lot of a destination for tourism and shopping and so forth. But when you have time, please do come visit Chicago. So this topic is fairly nearest and dearest to my heart, but the robotic surgery has really taken off especially in the United States in terms of performing robotic lung surgery. So now the robotic platform is the majority platform we're performing the operation in. But however, a lot of surgeons, trainees, and then those practice surgeons who are not used to robotic surgery now wants to adopt has been relying on industry sponsored courses and curricula for proficiency. However, the problem is, as you know, is that there's a significant amount of conflict of interest. And then these courses and curricula they provided doesn't really have a whole lot of accountability and then proper follow-up as how the trainees or surgeons do. And they do not really consistently report or utilize proficiency metrics or provide adequate feedback to improve. So how was it when I started robotic surgery back in 2011? Well, and during my obviously there was no robot. We did primarily did vascular or open thoracic surgery. But when I was first getting started, I had a 30-minute hands-on training with a local intuitive rep and then had a 2-day wet courses using some cadaver or pig model, and then went for one case observation and have five proctor cases, and that was it. Now you're certified to perform robotic surgery. And as you can imagine, there was a lot of sort of a personal learning curve that we had to go through. In the realms of a learning curve, there are some literature out there, especially for robotic surgery and robotic thoracic surgery, where a lot of reports mention that you require about 20 to 50 case for proficiency just to get started and be comfortable doing performing operations. Um, and obviously it depends on the personal variability and complexity of cases. But those complex cases like lobectomies and esophagectomy, data shows that proficiency continues to improve even beyond the case above 100. Other factors that obviously impact learning curve is type of robot you use. Now I'm in a generation where I use the older robots and so forth, but the latest iteration of robot, including XI and DV5, does seem to have features that, especially the bedside, instead of usually relying on bedside assistant for stapling, control of that stapling really has improved proficiency and the learning curve. And then having a dual console does matter too. And after gaining a proficiency, there's also a barrier, right, and to adopting a robot. And for junior faculties and senior faculty, the factors may be different uh, because it really requires, not only proficient doing an operation, but you're going to need a lot of patience and a lot of surgery in order to really improve and learning curve as you do more. But you're going to really need a time commitment, having a robot availability, and then justify whether doing a robot, and then going getting the over the learning curve, really balance out against your clinical and research and time commitments. So do I think that, for the residents or junior faculty who's learning the robot as versus those senior surgeons who are performing the operation, is there a different strategy to improving a learning curve? I used to think so, but the more and more I'm doing this, I really think that they're kind of equivalent. And my thought, our thought in United States is, really try to develop a strategy to improve, the residents and so forth, and try to really apply a similar principle for a more senior surgeon who used to be a vast surgeon, open surgeon, and apply to those to attaining a robotic skill sets. So what we really think that's very important in having a standardized curriculum. And a couple of years ago, we did a sort of need assessment of all the trainees across the United States, and found out that what are the factors that really matter after you graduate from your program in terms of adopting a robotic platform. And one of the key factor, besides the size of the training program, was the whether you had an established robotic curriculum in your program or not. And so, along with experts from, a panel from STS, we create a consensus panel to really develop a national robotic curriculum for thoracic surgery. And then, actually, based on this recommendation, we are physically actually creating a curriculum that will be instituted across all the training program coming very soon. And we had an ambitious start date around September this year, but that's probably going to be pushed back because sometime this winter time. But it is actually does getting built out. So what are in those components? So in the components of this curriculum, we really think that heavily on adopting a fairly good simulation platform. Obviously, you'll need to do some online modules and hand in service. How does the machine work? But obviously, there's a lot of digital virtual reality VR simulation that will require learning how to perform tasks of moving instruments in a virtual space to gain that sort of component prior to sitting as as a console surgeon. We also will require programs to provide a wet lab. Now, in the United States, there are society-led wet lab that is provided to the residents, such as the STS Bootcamp or AATS Robotic Fellowship, where the trainees will go to facilities and use a robot to actually perform operation and a various platform, including pig models or now this one we did it at the our own institution in our simulation lab where we got a pig heart and lung block, and so we kind of provided some heart, and then the lung we used it using a robot to perform a lobectomy and something like that. So you could have your own hospital or institution simulation lab like we did, and we try to perform at least once or twice a year. But you could go to these sort of a STS or ATS wet lab and then use a model like a kind heart and for instance to doing performing these operations. Um, we also, will require having a emergency conversion simulation lab, along with your team every year, not only for the trainees but also OR staff to be comfortable about how to convert these cases into open cases and then deal with the emergencies. Um, and then we really thought that, if you want to be a really good surgeon, having a skill set to best that assist in robotic cases really does matter. So we're going to require about 10 cases per year to show your proficiency in how to manipulate and dock, and then avoiding arm collisions, and avoid catastrophic event at the bedside. And there are obviously some study that definitely shows that surgeons who have a bedside experience have improved outcome as a consult surgeons. And then in terms of operation, we're really focusing on trying to create a case-specific milestone and breakdown of each steps of the operation, and providing a graduated responsibility, and then giving a timely feedback on in terms of performance. And then obviously assessment feedback is going to be very crucial, and working towards creating a fairly robust assessment and then feedback tool when we are doing this. But also do require a video review and analysis of the trainees in terms of performing operation by the staff surgeon at least once a year. And I think this is a very powerful tool to really improve outcome. And so, we will roll this out among the training programs, and we'll do a sort of a early, few center trial prior to launching in across the all the training program. But we have done this at our own institution, and these are sort of a requirement for our PGY level of residents, what we expect the residents to do, and so forth. And I do think that the robot really has a uh, uh, um, is a much better education tool than I would say vast or even open surgery, because when we do a robotic surgery, the resident really have to perform an operation. As you guys know, when we're doing open or vast operation, we could do a lot of operation at the bedside on the opposite side, and doing a lot of what we call sucker dissection, so forth, to perform the operation. But in robotic surgery, the resident really has to perform all these tasks. And so I do think that it's a much a better education tool for really learning how to do this. And then the nice thing about it is that we have a dual console, that while we're performing operation, if there's a resident struggling, we could assume the control, so we don't compromise the safety. And then these could be easily recorded and track performance. So this is me with my resident having a dual console, operating them side by side. And then we do have a bedside assisting uh, 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 physician assistant at the bedside, who's able to support and move the instruments while we're doing the operation. And besides the having a nice curriculum, there are technology that has improved uh, what we're doing in terms of learning curve. So we now routinely use the 3D lung model to pre-plan the operation. This is, I think, is a nice education tool in terms of learning about the anatomy prior to doing an operation, because there's a lot of variation, for instance, of both PA and the vein anatomy. And then give residents kind of kind of go through in their mind what the anatomy looks like, and then what to avoid and so forth. So we routinely try to create a 3D lung model. There are various platforms right now, and that will include one from Intuitive as well. But I do think that having some sort of model like this does help in terms of making the operation safer. And then another thing that I really like is ability to track the console time. So for instance, this is the one that I use with my residents. This is one of my senior resident. I mean, he performed like majority towards the end of his training of the operation, and rarely I had to kind of step in and then take over as a console side, so that really kind of able to track their performance when we're doing the operation. And then finally, the commitment. Once you're really committed to doing the robotic surgery, and just like anything we do, we really need to be consistent. So meaning you really should try to do at least a 1 to 2 case per week. and then and then try to build confidence. So don't start with the most very very hard operation. So when I first started, and at that time, I had no prior experience. I started with doing a wedge resection, but wedge could be then added with doing a nice complete lymphadenectomy. And then I did a thymectomy, which tend to be much easier. And then slowly move on from that to doing a lobectomy and segmentectomy, and even a lung transplant that we done last year. And then ultimately, though, when we're doing these operations, we have to be safe and then try to persevere. So try to, I say set a low expectation, meaning don't be afraid to convert to open if things are getting stuck and hard. And then persevere by, practicing and going back to do simulation, watch videos, and travel to watch other experts, and so forth. It's not, for instance, when we're doing what we call single port robotic surgery, I've traveled, watch other experts, to do how they do the operation as well. Even though at my age, because there are people that you could always learn from, and that is something that we all as a surgeons have to do throughout the rest of our lives. So in conclusion, learning curve for robotic surgery can be improved by having a good thought out standardized curriculum that includes simulation surgery, having some sort of specific milestone, and then graduate responsibility, and having a good objective real-time feedback, and then having some sort of video review and performance analysis by objective parties. And I do think that advancement in technology can guide operative planning and improving performance. We're in currently I'm working with some companies now trying to develop AI-based, tools to recognize important structures in the lung, and hopefully something like that in the future could really guide and really make a huge difference in the learning curve. But while these technology do improve, ultimately though, what really makes a difference, I do think, is that just like anything they would do in whether in surgery or trying to improve any performances, is you do need a personal commitment in time and effort to required to overcome any learning curve. Thank you very much.
Excellent. Thank you very much for an excellent presentation. Some questions for me to start off, if I may. Samuel, you've mentioned about the bedside assistant and the role of that in helping surgeons train to become better robotic surgeons. What's the role that encompasses in the bedside assist role?
Yeah, so I mean, obviously, the docking. I mean, bedside assist including port strategy, right? So understanding where do you need to place a port, and I tend to place a port along the line of stapling to so that we don't have to torque and stuff like that. From that to how to dock, and then how to really manipulate the arm so that there's less collisions, and so forth. And understanding all that, really, and having understand translate into how you operate in the operating room. For instance, to a point where now when I'm in the operating consoles, just by moving my arm and feeling the collision, I could direct the assistant at the bedside to do certain things with the arm, so that you lessen the time in terms of operation, because I know exactly what's happening, because from the bedside assisting, I understand how what the space you require from arm, right? And for instance, optimal space and optimal angles, so that I don't have to go back and forth between the bedside and then operating console. And then you could direct your assistant how to help you in terms of retracting and so forth. And then let's say you have a some sort of emergency, right? And so the arm's not able to move, or is stuck, or even a bleeding situation. Having a good understanding how to undock, how to manipulate out of those situations, really gonna make your operation much safer too. And so that's why I think there has been a lot of uh, uh, report in the literature that does suggest that having a good let's say assisting has translated into in terms of decreasing operative time as a consult surgeon.
Excellent. And can I ask about the number of ports and the position? Presumably, all the surgeons use different port positions or, how and placement. How does that fit into a national curriculum?
Yeah, so we don't direct, how or where to place the port placement. And back in the days when we were first rolling out robot, because we at that time we tried to standardize the port placement because we thought that, there's only so many proctors and teachers out there, and then having a different system of teaching may confuse people out there. Nowadays, I don't think there's really, where you should place the port. There's some idea, but my port strategy has changed too based on what I think is the best. So I do think that, but it being consistent where the port placement, I think is important in terms of surgeon. And then being having the repetition of having a similar view or similar where the arm is coming in, it matters because I think that it's going to be very hard for a trainee and something like that to constantly changing your port place around. Okay, so let's say your attending has certain port strategy, then you're going to see that most often. Then that's fine. As a trainee, you could do that. But let's say you have thousand cases or 2,000 cases. I don't, I don't. It doesn't matter that for me where the ports are. I mean, I could hop on my colleague who has a different port strategy than I do. I can hop in and then start doing the operation. So I do think that having a specific port strategy that makes sense to you is important, but having a consistency when you're going through the learning curve. And then after you gain the mastery, you could think about, maybe it's going to be better this way, and then change it.
Excellent. And do you think this port placement thing will soon become a thing of the past, going to single port robotics, that you only have one port, then you don't have to worry about all the other four ports are going to go?
Yeah, so we are doing single port strategy, but that has a different kind of problem and then challenges too. Now, thinking about where in the risk space we're going to put it in. There's a little minor adjustment. So the funny thing is that we met among fairly large users both in Korea, Asia, and America. What are the best strategy to, and we tried to come up with a consensus as we want to be consistent initially across the board. Um, so yes, I do think that maybe it's going to be a little bit different, but ultimately, though, in having an initial standardization, when we're early in adoption, makes sense, whether it's a single port or multi-port, and then having some sort of metric and so forth makes sense. But ultimately, though, as you get experience, you could ad lib it.
Excellent, thank you. And at the moment, Intuitive is clearly the market leader, and most of the training in the curriculum are going to be focused on the Intuitive series of robots. How does that make space or facilitate other competitors coming in?
Yeah, that's the one of the challenges, and obviously, Intuit has done a lot in terms of advancing robotic surgery in US and across the world. So the curriculum we tried to create was a little bit more agnostic towards specific types of a robot. That having said that, um, it's going to be very challenged for any other platform to try to drive in because not only is the education but also finances and hospital has to purchase and so forth, and not a lot of hospitals are going to have a fund to have a dual or similar platform across. And so it's going to be very challenging. But one thing I do think in especially in large institution like us that we value quality. So if the other robot has some sort of quality that triumphs, what Intuit is able to provide with their platform, a market will change fairly quickly. So if you're able to provide cheaper robot, right, cost that is much efficient or better in terms of technology, then there is going to be room to adopt different robot. just like how it was with anything, including medicines and drugs and so forth. But that means that whatever the company there is has to then have a much better product. And so we are trying to be open-minded about a lot of these things. And when we are showcasing, let's say for instance, in America, let's say Society of Thoracic Surgeons do open up robotic, webinars or have a hands-on courses. We try to open up and invite other platforms as well, so that at least we don't give all our sort of a control over to intuitive and say this is the only way to do it. Because I think having a monopoly on a system sometimes could be good, that things are standardized, but it does not improve innovations and improve quality. So as a physician, we really have to keep in mind that this is just a tool, right? And if there's a better tool comes out, right, we really need to be recognize that there are other it improves our patient quality, that we need to try to adopt those things as well.
And then Sam, can I ask, how then do you balance innovation and training? Let's say now you're using the Singapore platform. How do is it you're going to be using it all the time, and then the trainings take a back seat, like how when you started robotics? How do you balance it?
Yeah, so and that's a great question, and I always struggle with that. How do we, because I need to go through my learning curve too, and so I'm getting to a point where I'm still kind of about 50, 60 cases, single port number, but you want to kind of get to mastery level before kind of giving up the control. But having said that, there are other way to teach, residents, right? And then as I'm getting more comfortable, right, I could then, could give hand over to control over maybe, some part of it, like stapling and so forth. And so it could be, and then as I'm getting more comfortable, then it could gradually give majority of the cases over. So as I'm going through the learning curve, that doesn't mean the resident could do nothing, right? That's one. And then two, we're trying to get a dual console once again for the single port strategy too, so that trainees then could partake in part of the operation. And then we're trying to create a simulation now for single port for the residents as well. So, you know, um, but having said that, most important thing though is patient safety, obviously. And so you have to go through your learning curve prior to giving up the strategy. So, and you can't teach a resident unless you know how to do the operation well yourself. So I do think that there's going to be a little bit of bump as we're moving towards. Some of us will move with, but I don't think everything will be done with a single port, obviously. And I think multi-port is great. I still do 90% or 95% of my cases with a multi-port. But as we try to push the boundary, you could get residents still involved in these things gradually.
Presumably, you've always been a multi-port surgeon, and what's your initial experience for the single port approach?
Yeah. So obviously, the reason why we're doing it is because we think that maybe this has a better in terms of pain outcome, right? And there's no data, but we're trying to actually create a national register in America right now, and then hopefully with some of our partners in Asia and maybe in UK and Europe, we could create a national international registry, but and then start some trials in terms of outcomes, in terms of safety and pain and so forth. But my initial experience has been that at least for thymectomies and so forth, through some sternal approach, uh, you know, I do see difference when you talk to the patient in terms of pain and so forth, where patient maybe 2 to 3 weeks and so forth was complaining of pain and taking pain medicine. Was those patient with a single port, some patients rarely take even at 1 week after surgery, and I usually send them on Tylenol, Motrin, and they're not even on those things. So, in that sense, I do see the value in this strategy. But having said that, ultimately though, we need more data to say, especially with the lung surgery and so forth, the complication rate is just as comparable as multi-port. And then, oncological outcomes are just as comparable in terms of doing a very complete lymphadenectomies and so forth. So there's still ways to go, but I do see value in those is and so forth. And doing something like a thymectomy, for instance, I do think huge advantage in terms of doing an operation this way.
Excellent. Thank you very much for an excellent talk today. As always, there's not enough time for us to complete all our discussions. I want to thank again our sponsors, AstraZeneca, Medtronic, and Medillion, the Science of Care. Next week, we have Professor Hutan Ashrafian talking to us about the cost effectiveness of a robotic strategy. So once again, Samuel, thank you very much for staying up so late at night in Chicago and delivering excellent presentation as well as leadership in the world with regards to robotic surgical training.
Thank you very much for having me. And then good morning once
All
again.
right,
Bye bye.
goodbye.